first year cardiology resident under the guidance of my Dr. Akshay Bafna sir. Coming to break the streak of coronaries, now coming to the structural. This is stuck mechanical mitral wall leaflets. What shall we do? Also, we know the answer, but what we don't know that has happened. Coming to the history, a 60-year-old female, known case of rheumatic heart disease, severe mitral stenosis, severe MR, mild AR, known case of hypertension, diabetes, two comorbidities, underwent a mitral valve replacement in 2008 and redo mitral valve replacement in 2022 with St. Jude's 25 mm bileaflet mechanical valve. Presented to us with complaint of dyspnea on exertion, which progressed from grade 2 to grade 4 over a week as a result of stuck mechanical mitral valve due to non-compliance of anticoagulation. Because of repeated surgeries and non-compliance, cardiac surgeon denied further intervention and initially thrombolized the patient with streptokinase, but not much improvement was seen on the fluoroscopy. On admission and echo finding, there was mitral valve prosthesis in situ, leaflet motion were reduced, mitral gradient were 44/29, INR was 1.2. Here, the pre-fibrinolysis, we can see both the anterior and posterior leaflet are stuck, not moving, and post-fibrinolysis, we can see the posterior leaflet is moving well, but still the anterior leaflet is stuck. So, my task was to study the case pre-hand and study all the required complications which we are gonna see what we can do. So in this case, whenever we or a cardiac surgeon or we encounter a case of stuck mechanical prosthetic valve, three things are done. First, whoever did the surgery, redo the surgery, that is part of a cardiac surgeon. Second is thrombolysis that they have already done. Third is this is the one of the rare case where a cardiac surgeon is referring to a cardiologist, that is bailout surgery. We bail out from this complication. So these are the fluoroscopic images from the studies we have. Well presented case have been published by Dr. Lakshman Das sir and Vasu sir and Mullasari sir. So here are the fluoroscopic views which we have referred from their studies and further proceed for the case. Now I was standing to my attending. My attending was doing the case and I was standing as first watch. Whatever complication, I was thorough with this case, thoroughly read everything, every complications. I knew what next steps are gonna be and what else my attending will be asking. So one by one, we took the femoral approach by transseptal. This is the initial post-thrombolysis fluoro. We placed the right and left cerebral protection device and further went for transseptal puncture. By using the Mullin sheath and Brockenborough needle, we went further, took the TSP, as we went, we placed the Mullin sheath towards the mouth of the leaflets, and from there, a torquer was used to place across the leaflet and where the hinge of the leaflet is placed, and tried to cross a coronary wire across the hinges of the leaflet. Now we can see we used a Fielder FC wire and crossed it across the hinge. Now as we are trying to cross, the wire got stuck. You can see the wire is not moving forward and not coming backwards. This is the initial fluoro. And then second attempt we did, this was the complication I did not study. All the complications I was prepared, but this stuck coronary wire was not in my course. So my attending was seeing me and I was seeing him and I was like, shall I call the cardiac surgeon, sir? And he was like, what's the next step? So I thought maybe pushing the Mullin sheath forward and helping the Mullin sheath and tugging the wire might cause it. But that did not happen. We again tried to torque the wire, cross it across and remove it by little force, and that fortunately came out. And what fortunately it did, that it released the leaflet, oh, sorry. What it did, it released the anterior leaflet a little bit. Further, then we crossed it from across the leaflet and we used serial dilation of a coronary balloon 5 into 10 mm, and by gradually updating the size of the balloon, we opened the leaflet and this was the final result. So that was a short complication of stuck coronary wire in a stuck mitral prosthetic leaflet. This was our data. We have done 7 such cases, age ranging from 47 to 60 years. Most common cause was found was non-compliant to the treatment. Due to economic constraint, we used a Mullin sheath with torquer, and serial inflation of the coronary balloon was done. And what is the key take-home messages? Despite the education, patients don't maintain the INR. So strict monitoring, lifestyle changes are important. Strict follow-up is important, and transcatheter balloon-assisted release of stuck wall can be a bailout in patients who are unfit for surgery or thrombolysis.
Thank you.
What were the TE findings? What were the TE findings?
Sir, unfortunately, TEE, we do not cater the facility.
So then, how come you can differentiate between the thrombus or pannus? How we will plan that whether you should go for the procedure or not?
Sir, yes, sir. Presentation, and since as there were no embolic phenomena, that could be either pannus or initial thrombolysis was done. So we mostly thought, because one leaflet was moving, so we thought it is most probably thrombus. If pannus would have caught that.
What should be the pressure of the balloon? That leaflet may get detached from the annulus. What should be the pressure of the balloon? Second, that wire can get caught somewhere and you may not be able to remove that wire.
Yes.
So it should be between the leaflets. But your wire went behind the leaflet probably.
Yes,
so probably I think the study is ongoing
I
for this
think
trial.
one reason is that sometimes in a bileaflet tilting disc valve, it is the hinge mechanism which is faulty. And what he has managed to do is he has managed to release the hinge. Fortune favors the brave. He really got lucky here. Just elegantly described by Madras Medical Mission a few years ago. One of my colleagues actually, in an extremist situation, put in a sheath into the LV under echo guidance, put in a wire, and released the stuck valve, and thereafter used a closure device to close that. So people have done exotic interventions like this, but
It's a fantastic case, fantastic.
but my suggestion, next time if you have to do, because you've done 7 cases, you're very experienced, use an Agilist sheet. At least you can steer it.
Yes, sir.
Because that will be an advantage over using a plain Mullin.
I think 2 things actually. One is the Agilist sheath, and second is a puncture should be posterior and inferior. You can do a TE guided puncture in such situations, like what we do for TMVR.
Yeah.
So the crossing becomes much easier. And it's not the pressure of the balloon, it's the size of the balloon. You go gradually up, basically starting with a 2.5. If the smallest balloon which releases the disc is sufficient, you don't have to go to a higher size balloon.
I'm just, this is the first time I've seen this, but I just can't imagine how you don't get wire entrapment or equipment entrapment given what you're trying to deal with, you know, and you're working through a valve which is trying to close, and whenever you retract your equipment, that's when you get entrapment, you know. So I'm not at all surprised that you got your wire stuck, you know, and good job for getting it freed.
Thank you, sir.
So instead of doing so much of things, considering it would be the small clot, then why not to give a random DC shock and reset the rhythm just to mobilize that hinge?
You know, actually, these patients are very unfortunate. Especially, firstly, there was a big All India Institute series on thrombolysis in stuck valve, and it was pointed out that despite the initial euphoria of success, because you thrombolize and you get good flows, they always have secondary thrombosis.
Sure.
So surgery is possibly a much better solution. Now, in a redo situation, your surgeon also has to be brave, just like the cardiologist here was rather brave, and they took on something. Probably, in the long run, something which has to be done for this patient has to be surgical, because I'm not sure whether this is going to be a durable treatment.
So basically, I am asking whether we can reset the rhythm by giving a random DC shock.
Yeah, but you know, none of these things are going to really work, even if it is atrial fibrillation, which you think is causing it, and you reset the rhythm. In a diseased heart, it is going to go back to atrial fibrillation. So those are not something you can really, hang your hat on. But what I would suggest is motivate your surgeons to operate.
It would be very risky to shock. There is a thrombus on the wall, so it will dislodge.
Okay,
very
we'll
exotic.
Now he is doing the so much of procedure.
But he is putting a protection over here. He has put a embolic protection. He has done.
Yeah,
He has
this
done a
is
protected.
this is
this
like
thing.
the first time we did a balloon mitral in the presence of LA clot. We put a bilateral carotid protection device, and we did it. But you know something, the patient had a posterior circulation stroke.
Yeah.
So nature has ways of getting the better of you.
Yeah, but I think Madras Medical Mission has a large series which is published.
I know that. I'm aware of that. But all the same, I would still urge you to read, since you've read all the papers, read Rama's article where he has done compared about 190 odd cases where they've compared thrombolysis versus surgery, and they've done the follow-up of thrombolysis, a follow-up of any percutaneous mechanical intervention, and it has not been found to be satisfactory.
Brilliant case, fantastic.
Thank you, sir.